Ladies and gentlemen, dear friends, thank you for being with us today with another webinar of the European Society of Gynecology. Today, the topic is of fantastic interest, is the tailoring of endometrial cancer prevention and treatment in current medical practice. And we will have three lecturers, Professor Andrea Giannini, Dr. Francesco Multinu, and Dr. Pino. And the first lecture will be done by Professor Andrea Giannini, then I will introduce him. And then after his presentation, I will introduce Dr. Francesco Multinu and Dr. Pino from the International Institute, European Institute of Oncology in Milano. And Professor Andrea Giannini is a senior researcher at the University of Pisa, specializing in gynecological endocrinology, menopause, and robotic surgery. His field of interest is the study of robotic treatment of endometrial cancer and the innovation of enhanced recovery after surgery, ERAS protocols, for the management of oncologic and non-oncologic patients treated with both traditional and minimally invasive surgery, with particular interest in the discharge on the same day of surgery. He has published over 70 papers and 20 book chapters. Andrea, you have the microphone, then you can share your screen, and then you can start your lesson. And later on, we will have that of our colleagues of the European Institute of Oncology in Milan.
Thank you, Professor Genazzani, for involving me in this event. Thank you so much to the audience. I will talk about intercepting endometrial cancer risk factor across the women's life. So when we talk about risk factor according to the reproductive period, it's important to focus the attention on the fact that there are different risk factors according to the different season of the life of women. So in fertile period, early and late fertile period, perimenopausal period, and postmenopausal period. The most important aspect is to evaluate in the first part of the reproductive period is to evaluate the condition of anovulation. There are several causes of anovulation and several causes, for example, hyperandrogenism, hyperprolactinemia, anorexia, and stress, and so on. And also the assumption of some medication. What is important is that the anovulation can present with amenorrhea, irregular menses, spotting and bleeding, and abnormal uterine bleeding, and heavy menstrual bleeding. The consequence of the chronic anovulation in general, in the general population, is infertility and the increased risk of endometrial cancer and sometimes breast cancer. Probably because the anovulation event could impair the physiological process of desidualization. That is something very important for the physiological act of the hormones of endometrium across the normal menstrual cycle. In fact, there is, at the basis of this pathological process, there is the theory of unopposed estrogen. This theory suggests that endometrial cancer risk is increased in women with high plasma level of bioavailable estradiol or low plasma level of progesterone. Reproductive risk factors that increase the lifetime exposure to unopposed estrogen are the early menarche, the late menopause, the anovulation event, nulliparity, and the intake of tamoxifen in patients with breast cancer. One of the most important causes of anovulation and a possible risk factor for the development of prenoplastic and neoplastic lesion of the endometrium is the polycystic ovarian syndrome and the hyperandrogenism. Both of them are associated with obesity, metabolic syndrome, diabetes mellitus, and the condition of insulin resistance. That all of that can contribute to heightened cardiovascular risk and events, and in general can increase the possibly in onset of prenoplastic and neoplastic lesion of the endometrium in terms of endometrial hyperplasia and endometrial cancer. And this is a very interesting cartoon that summarizes the process which are the clinical phenotype of PCOS patient and the related mechanism of action of endometrium and some molecules. For example, the luteal dysfunction, this patient can lead to the hyperandrogenism and the progesterone resistance. And with the aim of ROS, so the stress oxidative process, we have an impairment of endometrial receptivity, can lead to an hyperplasia and finally to endometrial cancer. Also, obesity have a strange mechanism of action that can be involved in the association with this kind of condition, metabolic condition, and the endometrial cancer risk and survival. So usually the obesity is related to the dysfunction of endometrial and to the condition of endometrial cancer by the expression of endogenous sex steroid hormones, insulin resistant and hyperinsulinemia, the hyperexpression of adipokines and inflammation, and some genetic factor that can lead to a creation of an hyperestrogenic, hyperinsulinemic, and pro-inflammatory state. The proliferation, the promotion of the proliferation of endometrium that can accumulate somatic and genetic events and subsequent malignant transformation. Moreover, obesity can lead to a pro-inflammatory milieu to an hyperestrogenic state because the conversion of androstenedione and androgen in general, the conversion to estrone and the aromatization of androgen to estradiol by adipose tissue, so leading to a natural deficiency of progesterone according to the menopausal condition, and this can contribute to the obesity driven an opposite estrogen excess, so leading the theory behind the endometrial carcinogenesis in this kind of patient. Concerning the role of insulin resistant and the hyperinsulinemia in endometrial cancer is interesting because obesity per se is able to give a high level of insulin, so hyperinsulinemia, that can lead to the reduction of sex hormone binding globulin, the rise of insulin growth factor 1 and other insulin growth factor like factors to increase the rate of free testosterone. Moreover, it is important to evaluate the change of the visceral adipose tissue and the abdominal subcutaneous adipose tissue across the menopausal transition and after the menopause. It's important because the amount of visceral adipose tissue radically dramatically increase, and it can be a cofactor for the oxidative stress and damage. Here, there is a very interesting cartoon that summarizes the role of the chronic anovulation on estrogen and progesterone levels, the androgenic increase, so the concomitant role of obesity, insulin resistance, the alteration of immunity in endometrium and in general in the perimenopausal women, and the chronic expression of inflammation that can bring a cofactor for the endometrial dysfunction before and later for the change in preneoplastic and neoplastic lesion. If we check the clinical issue of this discussion, it's interesting to note the association between obesity and endometrial cancer. So it's interesting to underline that patient with obesity, every 5 points increase in BMI, there is an association with a 54% higher risk to develop endometrial cancer. And the lifetime risk of endometrial cancer in women with a BMI greater than 40 is 10 to 15% during the lifetime span. So it's a very important percentage of risk in patients who experience the obesity condition. Whether the weight gain during adulthood or the body adipose distribution are more important than BMI is something that is a matter of debate. There is an interesting association between the class of obesity and the risk to develop endometrial cancer. And it is, there is a small variation between type 1 and type 2 endometrial cancer, but it's interesting to note that the odds ratio for the development of endometrial cancer is different according to the different class of obesity. And patients with a BMI greater than 40 are more likely to develop less aggressive histology. And patients with class 3 obesity are more likely to present a stage 1 disease or low-grade histology. And the higher BMI is associated with the development of endometrial cancer at a young age. Again, the distribution of adipose tissue does not appear to be a factor in the endometrial cancer risk, but some growing evidence suggests that higher visceral fat percentage was a negative prognostic biomarker in non-endometrioid endometrial cancer compared to subcutaneous fat. This could be important for estrogen production to the increase of aromatase activity. Anyway, this is this is still a matter of debate. The literature is poor, and data are not solid for giving a good estimation. Concerning diabetes, it's curious to underline that endometrial cancer, patients with diabetes have an increased risk of endometrial cancer twice respect to the non-diabetic population, so healthy population. The mechanism of action is the same we told before. And what about the perineoplastic lesion of the endometrium and its risk factor? It's interesting to repeat that the great risk is not related to the amount of the estrogenic stimulation, but the duration of estrogenic stimulation. And it is important concerning the exogenous hyperestrogenism, the endogenous hyperestrogenism that we can find in several clinical conditions. So the mechanism of action is the same we told above. But anyway, considering the perineoplastic lesion, we can affirm that patients with obesity more than 30 show 4-fold increased risk to develop endometrial hyperplasia with atypia. And patients with BMI more than 40 show 30-fold increased risk to develop endometrial hyperplasia with atypia, and 33 and 23-fold increased risk of endometrial hyperplasia without atypia. So it's important also to consider that the chronic anovulation, the PCOS, in this kind of patient, there is a risk to develop endometrial hyperplasia with atypia before 50 years of age. So this is a very important aspect to check in this young patient. Also, considering the risk factor for the development of a perineoplastic lesion, is interesting to underline that nulliparity, all patients with nulliparity have the odd ratio to develop this kind of lesion in 2.8 and infertility 3.6. Probably because nulliparity and infertility are independent risk factors for endometrial hyperplasia and endometrial cancer, and both of these conditions are related to chronic anovulation, obesity, and PCOS. So the risk of a complex endometrial hyperplasia with atypia is inversely related with the number of deliveries. When we talk about the prognostic factor for the development of neoplastic lesion from perineoplastic lesion, the most important aspect is the presence of atypia, because this is the most important feature. You know that typical hyperplasia or herein and endometrial intraepithelial neoplasia are associated with the progression to endometrioid cancer in up to 28% of cases, and the presence of concurrent endometrial cancer in up to 33 cases. So it is very important. Why the hyperplasia without atypia show a progression to endometrial cancer in up to 5% of cases. So there is a very different situation according to the presence of the absence of atypia. And this is summarized very well in this important work, paper of Armstrong that you can read without any problem. You can find on PubMed. This is a very important milestone in this kind of preventive medicine. Another risk factor for endometrial hyperplasia is the assumption of estrogen-only hormonal therapy. You know that now the presence of progesterone is mandatory, but it's important to note that in several studies and in the past, sometimes this therapy was used without a balance of progestin. So it's interesting to note this kind of evolution to a preneoplastic neoplastic lesion. Also, the use of peculiar serum such as tamoxifen can increase the risk to develop endometrial hyperplasia and endometrial cancer. Another risk factor for the development of preneoplastic lesion, neoplastic lesion is the Lynch syndrome. And it's interesting because the risk of endometrial hyperplasia in this kind of patient is not certain, is not sure anyway. 40 to 60% of patients with this kind of syndrome can develop endometrial cancer during the lifetime. So this is a very important aspect that the colleagues can treat in a very exhaustive way. How to intercept this lesion? It's important to check for symptoms, to check for, in this case, for the bleeding. The bleeding is one of the most important signs in this kind of, when we talk about the interception of a risk factor. And you can see that abnormal uterine bleeding is one of the main symptoms, but the endometrial pathology and the cause of abnormal uterine bleeding can radically change across the different during the dependent stage of reproductive period in women. So the causes are very different according to the reproductive age, the perimenopausal age, and the postmenopausal age. When we check for abnormal uterine bleeding, we have always to evaluate the Figo-Palm conic classification that considered structural, so organic and non-organic entities. And we have to be very attentive about the presentation of abnormal uterine bleeding, especially the bleeding in the postmenopausal period. Because, yes, it's important to note that the percentage of women with postmenopausal bleeding that have an endometrial cancer at 9%. So, and if we check the percentage of women with endometrial cancer who have vaginal bleeding, this percentage is 90%. So it's safe to think that endometrial cancer gives this information. And often endometrial cancer can give us a great help for early diagnosis because endometrial cancer have a high rate of bleeding. What is the perfect, the adequate workup for this kind of symptoms and presentation? It depends a lot of factors because guidelines are able to standardize some flow chart, but it's important to start from the history and the physical exam of the patient to check for the amenorrhea condition, maybe for PCOS condition problem and anovulatory state, chronic and temporary, and to check for the condition of the bleeding and the characteristic of the menstrual cycle, the spotting period, to think about the presence of spotting and abnormal uterine bleeding across the late reproductive period and in premenopausal, perimenopausal, postmenopausal period. And this is very important. Moreover, we can also perform a laboratory test and to check for imaging, and endovaginal sonography is the most important aspect. We can perform an hysteroscopy and with or without histologic sampling. Of course, endovaginal ultrasonography is the most important investigation to study the anatomy and the morphology of the uterus and the ovaries when the thickness of endometrium is more than 5 millimeters in postmenopausal period, or someone told 11 to 15 millimeters in perimenopausal period, or if there is a doubt of detection of polyps, myoma, adenomyosis, or other structural abnormality of the uterus. When perform hysteroscopy in this kind of patient, you know that is in the indication of hysteroscopy are a lot, and the hysteroscopy can be performed both for diagnostic and operative purposes. And we have to know that the finding of hysteroscopic exam in most of the cases is a normal endometrium. The finding is in close to 50% of the cases normal endometrium. So we have to select the patient. If we look at the abnormal uterine bleeding, it's important to note that hysteroscopy can have a role in the detection and interception of preneoplastic, neoplastic lesion in premenopausal women if the thickness is 11. And if it's important if there is a persistent abnormal uterine bleeding that is not responsive to therapy, and in all these cases there is a suspected anomalies according to the Palm-Cohen classification. While in the postmenopausal period, it's important to perform this kind of exam in patients with endometrial thickness more than 4 millimeters, and even less than 4 millimeters with the risk factor for endometrial cancer. And persistent abnormal uterine bleeding. So this is the most important indication for performing an hysteroscopy. Is it safe to perform hysteroscopy? Yes, it is. Even if we have a strong suspect of cancer, it's safe to perform this kind of exam because the hysteroscopy seems not increasing the risk of progression. Even in in a case of patient who later underwent hysterectomy for grade 3 endometrial cancer. This is a very interesting study that ensures in the fact about the cytology is the positive cytology is lower, and there is no problem even with the advanced stage endometrial cancer in performing an hysteroscopy. So we can perform without any problem. And what about some risk factor that appear to be significant when present for the development of preneoplastic, neoplastic lesion? What about the polyps, for example? Should we remove all polyps? This is still an open debate. There is some evidence that show that if you remove a polyp, you can decrease the risk of cancer, you can decrease the risk of future bleeding, and you can protect by the development of cancer. There is also a theory about the observation. So we can observe because it seems that there is no survival advantage in the diagnosis of endometrial cancer in a symptomatic postmenopausal patient versus symptomatic patient. There is a small amount of polyps that can underwent a regression, but it's interesting to note that the rate of polyp that have a spontaneous regression is very low if the polyp is more than 10 millimeters. So it's important the size of polyp. It's important the size, and this is crucial, the presence of symptomatic polyps, because polyps in presence of abnormal uterine bleeding, above all in premenopausal and postmenopausal women, is important to remove because these kind of polyps are more related to the development of preneoplastic and neoplastic lesion. Moreover, when we have to check to make an assessment of the patient with abnormal uterine bleeding, is important to check for the menopausal hormone therapy the patient is undergoing, because there is a little bit change in the rate of abnormal uterine bleeding according to different different hormonal therapy. Anyway, to undertake or menopausal hormone therapy is something that can protect by endometrial cancer and endometrial lesion, because as we previously affirmed, this kind of therapy now is balanced, and there is the presence of progestin in all the patients with the uterus not hysterectomized, so it's important. And what about the endometrial assessment and biopsy when required? It is important to focus not in the young patient, but in patient in the late reproductive period. So in the patient who are 40 to the menopausal situation. This is important because in patient over 45 years of age, it is important to check for family history, for the general health status, but it's also important to perform a biopsy in every kind of setting and condition. Why is very important to perform the biopsy in presence of abnormal uterine bleeding in the postmenopausal women, in older women more than 60 years of age, and in all patients, even younger, but with endometrial thickness more than 4 millimeters. This is a very interesting paper that you can read, because it's a very interesting. The focus on the patient older than 60 is a very important aspect. And it's interesting also to evaluate according to the different use and flow chart of different hospital and guideline, but it's important to check for the method, because for the biopsy of the endometrial histology there is a sensitivity and a specificity that are very high according to dilatation and curettage and pelvic ultrasound examination, hysteroscopy with the biopsy, but so we can check also about the cost of the different national health system and cost for the other structure. So approaching to the conclusion, we can affirm that there are some independent risk factors for endometrial hyperplasia, endometrial cancer. The presence of polyp, the presence of Lynch syndrome is important, the obesity, and there are some of protective factors such as the oral contraceptive pill, of the use of early method of diagnosis such as ultrasound and endometrial biopsy by dilatation and curettage. Considering for the counseling purpose, it's important to note that diagnosis of endometrial cancer was lower among women using hormonal therapy. This is very important because this notion is important for our patients during consultation activity. Endometrial cancer in patients with postmenopausal bleeding and polyps is important because the presence of endometrial cancer is 3%, so it's a very high percentage, and we have to pay attention to the amount of patients who can develop endometrial cancer before 50 years of age, that are the 5 to 15%. So this is this is not a small amount of the population. It is important because the early detection of a risk factor is mandatory. And the risk factor is clear, are different according to different geographic region, according to in the fact that the presence or not of postmenopausal bleeding. So to reduce the risk, there are several strategies. It's important to treat the chronic anovulation in the young women because it can be associated with the PCOS or hyperandrogenism or different condition that can be treated. So we have to treat the women with this kind of condition. We can treat with different compound, different molecule, progestin containing oral contraceptive pill, and cycling or progestin, other kind of progestin or IUD. This is not a problem. You can choose the perfect molecule according to the patient need and the requirement. And the addition of progestin to postmenopausal estrogen for us is mandatory and decrease the risk of perineoplastic and neoplastic lesion, even if the treatment is, you can treat the patient with 12 to 14 days month is effective to reduce the perineoplastic and neoplastic lesion. Moreover, it's important to have a prevention strategies for the resolution of this metabolism that create all these conditions for the endometrial proliferation, for the accumulation of somatic genetic events and the malignant transformation. In this view, is important to have to perform and to propose a risk-reducing lifestyle and pharmacologic intervention for the weight loss, to improve the physical activity, to prescribe exogenous progestin, anti-inflammatory drug, and to manage the insulin-resistant condition. All these strategies are something for the primary prevention of endometrial cancer and perineoplastic lesion. And of note is the constant onset of new artificial intelligence and deep learning study research for the development of predicting future risk tools. So this is very interesting because in the future we can achieve this kind of instrumentation for the tailoring of a personalized approach, both in terms of prevention and treatment, because the final aim for the to take care of these women is an early detection, is of to intercept the risk factor, to identify the patient at risk, to have a early diagnosis, and to treat and follow up in a very personalized way. Thank you for the attention.
Thank you very much, Andrea, for this beautiful presentation. And then if you can close, I will invite everybody to write your question in question and answer. And we will move now to the second part. The second part will be done by two persons, both of European Institute of Oncology, Dr. Francesco Multinu and Dr. Ida Pino, is tailoring endometrial cancer prevention and treatment in current medical practice. Dr. Francesco Multinu is an experienced gynecological oncologist with international training and a strong focus on clinical and translational research. He has collaborated with prestigious institutions such as the Mayo Clinic in Rochester and the Istituto Europeo di Oncologia in Milan, and is a founding member of the Imagine, fostering innovation in gynecological oncology. He's passionate about advancing research and improving patient care. And Dr. Ida Pino, she's assistant at the Preventive Gynecology Unit of the European Institute of Oncology in Milan, with expertise in hereditary cancer syndrome and high-risk patient surveillance. She specialized in fertility sparing treatment and advanced gynecologic ultrasonography. I thank both of you, Francesco and Ida, and I leave you the microphone. Please, if you can share your screen, we will go on.
Yeah. So we can start. Good afternoon. It's a pleasure to be here, and I'd like to express my gratitude to the organizer and to Dr. Multinu for the opportunity to collaborate on this tandem presentation. The endometrial carcinoma is the sixth most commonly diagnosed cancer in women. A significant and rising number of cases are diagnosed every year in Europe and the industrialized countries. As you have learned in the previous presentation, a lot of risk factors are linked to endometrial cancer. Although traditionally considered a postmenopausal condition, 20% of endometrial cancer are detected in the premenopausal women, and 3 to 5% are younger than 40 years. The incidence is further increased by the rising average age of the first pregnancy. Let's take a moment to talk about the perineoplastic condition, focusing on the hyperplasia with and without atypia. These two conditions are very different in their risks. Hyperplasia without atypia has a low risk of progression to cancer, and in the majority of cases regress spontaneously. On the contrary, hyperplasia with atypia carries is a significantly higher risk of underlying malignancy, up to 60%, or progression to cancer, up to 27%. For endometrial cancer and atypical hyperplasia, the standard treatment includes total hysterectomy and bilateral salpingo-forectomy with or without lymph node staging. This approach significantly impacts the quality of life and fertility, especially in younger women. However, fertility-sparing treatment represents an alternative strategy for a carefully selected patient. In 2023, two big European societies collaborated to develop a clinically relevant and evidence-based guidelines on fertility-sparing treatment aimed to improve the quality of care for women with endometrial cancer. The key topics of the guideline, as well as our presentation of today, are the patient selection, the tumor selection, the diagnostic approach, the treatment protocols, outcome, and follow-up. Let's start for the first point, the patient selection. Not all women with endometrial cancer are candidates for fertility-sparing treatments. Patient selection is crucial, and eligibility must be determined through a comprehensive assessment of their reproductive potential and desire to conceive. Patients should be referred to specialized centers with a multidisciplinary team in order to ensure a comprehensive support and the best possible outcome. Let's move to the second point, the tumor selection. If not all women who want to preserve fertility are good candidates for fertility-sparing treatment, not all tumors are suitable for this treatment. In fact, obtaining a second opinion by an experienced histopathologist is recommended in every case of fertility-sparing treatment, and it can be performed if the case meet the following criteria. When we have an atypical hyperplasia, an endometrioid intraepithelial neoplasia, a G1 endometrioid carcinoma without metastatic disease or myometrial invasion. The cornerstone of diagnosis of endometrial cancer is biopsy, and several methods are in use. A blind approach will sample less than 50% of the endometrial cavity, with a high rate of false negative results. On the contrary, the overall sensitivity and specificity of hysteroscopy for the detection, of course, of endometrial cancer are very high, or 86, 99% respectively. So, blinded techniques should not longer be offered to our patient. Which is the best technique is the hysteroscopic guide endometrial biopsy using the GRASP technique, who demonstrated the best performance and should be the technique that we prefer to have our diagnosis. Let's move to the third point, the diagnostic approach. One of the most important inclusion criteria is the absence of myometrial invasion. Gynecologist plays a crucial role in the preoperative assessment, and transvaginal ultrasound performed by an expert examiner is a valid alternative to pelvic MRI, offering a sensitivity of 75% and specificity of 82% for detecting deep myometrial invasion. On the contrary, assessing shallow myometrial invasion is significantly more complex and remains a challenging task. Here are the images of one of our patients, a 32-year-old woman, diagnosed with a G1 endometrial carcinoma. The intracavitary heterogeneous lesion is clearly visible on both MRI MRI and transvaginal ultrasound. The junctional zone appears slightly heterogeneous on the anterior wall. However, this was fortunately due to the entry of the vessel into the lesion. In fact, our patient reached the complete response in 6 months and had a pregnancy with IVF. What is the best way to evaluate the myometrial invasion? The experience. In fact, the subjective assessment showed the highest diagnostic accuracy compared to objective method, for example, the most used Carlson ratio. The probability of extrauterine disease in early stage low risk endometrial cancer is extremely low. However, it must always be ruled out through an accurate imaging, especially CT. Additionally, ovarian involvement must also be excluded as part of the pretreatment evaluation. The ovarian cancer occurs in up to 29% of patients with endometrial cancer. In such case, and is more likely in younger women. In such cases, ultrasound becomes an important ally. I have some problem with the video. I'll try again. Okay, perfect. Here we present the case of another patient, 27 years old, diagnosed with endometrial carcinoma and synchronous endometrioid ovarian cancer. She underwent a dual fertility sparing treatment, achieving the complete response in 6 months and later conceiving spontaneously. She is currently disease-free and retains her uterus and residual ovary in place. We go to the next point, the treatment protocols. Fertility sparing treatment for endometrial cancer and its precursor was traditionally continuous progestin-based therapy. On the slide, you can see the different strategies that have been adopted over the years. However, it's important to underline that there are no randomized control trial comparing the different medical treatments available. Medroxyprogesterone acetate and megestrol acetate with or without intrauterine device are the most commonly used progestins, and the majority of the studies report data on their use. Most of the data on fertility sparing outcomes come from reviews and meta-analysis of retrospective studies, often using different therapeutic protocols and providing cumulative data on atypical hyperplasia and endometrial cancer with overlapping results. This slide presents a review of 23 studies involving 300 patients with endometrial cancer G1. The most common pharmacological agents included medroxyprogesterone acetate and megestrol acetate. The median duration of therapy was 6 months. The oncological outcomes showed a complete response in 76% of the patient, while a 22% of no response, with a recurrence rate of 34%. Same results in this systematic review and meta-analysis, which also includes data for atypical hyperplasia with a larger sample size, over 1,000 patients. It shows a pool complete response rate of 71%. And among the different treatments, the combination of levonorgestrel, IUD, and progestins stand out with the highest complete response rate of 88%. 6%. The recurrence rate is around 30%, with the IUD demonstrating superior outcomes in reducing recurrence. Additionally, the pooled pregnancy rate was 35%, with the levonorgestrel IUD used alone showing a lower rate, 18%. Further randomized control trial are needed, of course, to confirm these results. But at the end, what do we suggest to our patient now with this data? For oral progestin, prioritize megestrol acetate due to its higher bioavailability, favor high dose administration, combining oral progestin with the intrauterine device to reduce the side effects and improve compliance. But can we do more? Metformin is commonly used in the treatment of diabetes, has shown significant anti-cancer effects, and has been associated with an improved survival outcomes in endometrial cancer patient. Currently, we are waiting the results of an ongoing randomized control trial, the Felicia trial. In the meantime, data from a meta-analysis demonstrated that the complete response rate was significantly higher in patients treated with a combination of progestin and metformin compared to progestin alone, both in atypical hyperplasia and endometrial cancer group. Furthermore, metformin was also found to improve pregnancy rate, offering an additional benefit for fertility preservation. In our experience, metformin has also shown encouraging results. In this study, we evaluated the 3 different therapeutic approaches used at our institute over the time. It included 75 patients with endometrioid G1 endometrial cancer. At 12 months, 75% of the women that achieve a complete response, and the group treat with megestrol acetate, levonorgestrel IUD, and metformin demonstrated a statistically significant lower risk of recurrence compared to the other regimens. Additionally, was observed also an increased complete response rate, although this difference did not reach statistical significance. Can we improve further? Matson was the first to describe the 3-step hysteroscopic resection technique for focal endometrial cancer. This approach involves the resection of the tumor lesion, the adjacent endometrium, and the underlying myometrium. It is an effective method for ensuring an accurate tumor staging and enhance the therapeutic efficacy of the subsequent progestin-based therapy. Unfortunately, the endometrial cancer patient, the disease is rarely focal, and Matson's technique will not be applicable as it could lead to an Asherman syndrome. However, with the use of tissue removal devices, we can perform a superficial endometrial resection, preserving the basal layer. This approach can be performed in an office setting and can be immediately followed by the insertion of the levonorgestrel IUD. Do we have data on the impact of hysteroscopic resection on the success of fertility-sparing treatments? The available studies are small scale but encouraging. As shown in this slide, hysteroscopic resection in combination with the progestin therapy demonstrated a higher complete response rate and better obstetrical outcomes compared to medical therapy alone. For example, the Falcone study reports a complete response rate of 96% and a pregnancy and live birth rate of 93% and 87% respectively. This combination therapy so represents a promising option for managing endometrial cancer infertility sparing treatment. So let's move to the last topic, outcomes and follow-up. According to the guidelines, the recommended duration of the therapy is 6 to 12 months and should not exceed 15 months. To ensure the success, of course, safety of fertility sparing treatment, a careful follow-up with the maintenance therapy is crucial. Success is determined by 2 consecutive complete response at endometrial biopsy with a minimum interval of 3 months. Clinical and ultrasound examination should be conducted every 3 months and the endometrial histology performed every 3 to 6 months. Of course, patients are encouraged to actively try to conceive as soon as the complete response is confirmed. Assisted reproductive technologies should be considered to improve the chance of success. Natural conception may be considered, but in a defined time frame. And for women who declined the surgery after delivery, maintenance therapy with levonorgestrel ID are strongly recommended to reduce the risk of recurrence. Here you can see the images of one of our patients in follow-up. So we reached the end of the first part of the presentation.
Okay.
Yes, thank you very much, Ida. And we will follow with Francesco. You will go on.
Can you hear me?
Yes,
Yep.
we want to have also your sharing of your slides.
Good afternoon, everyone. It's truly an honor for me to be here, and I would like to start thanking the organizing committee for inviting us for this important webinar. I'm also grateful for the moderator for the kind introduction and for guiding us in today's session. I'm really excited to share with you some of the insight from both our clinical and research experience in this evolving field, and I look forward to engaging you in a meaningful discussion with you all. This is the agenda, the brief agenda of the last part of our presentation. Most importantly, just to stress this point, it's important to underline that all the suggestion data we presented today are not based on level 1 evidence, because there are not randomized data on fertility sparing treatment in endometrial cancer. So this implicates that all recommendations we are providing you are only supported by observational data and professional experience and consensus conference developed in the literature. Just a brief introduction on the molecular classification of endometrial cancer. As all you know, the classification of endometrial cancer changed dramatically over the last 40 years, starting from the Bachmann dualistic model of endometrial tumorigenesis, classifying patients in grade 1 and grade 2. We arrive to the TCGA molecular model developed in 2003. The TCGA basically was developed because the dualistic model developed by Bachmann demonstrate poor reproducibility in terms of histotype, especially for high grade, poor reproducibility of grade between biopsy and hysterectomy, and also poor reproducibility between inter-observer. And this was leading to an appropriate risk stratification with a consequence of under or over treatment. For this reason, TCGA, trying to improve survival and outcome patient with endometrial cancer, developed this model, which was able to identify 4 subgroups. Those 4 subgroups, however, the analysis, genomic and proteomic analysis performed by the TCGA were too costly and difficult to apply broader. So for this reason, in 2014 and 2018, the PROMISE group and the Transporte group developed a simplified model which, using polysequencing and immunohistochemistry for mismatched repair proteins and p53, was able to classify endometrial cancer in one of those 4 classes. Let's see what is the implication and the impact of molecular classification on fertility sparing treatment. This is a very important recent article published by a Chinese group focusing only on patients with atypical hyperplasia. They performed molecular classification on 52 patients with endometrial hyperplasia, atypical hyperplasia, and interestingly, they show that patients with p53 wild type had a complete response rate at 12 months much higher and statistically significant higher than patients with p53 abnormal. Similar for patients with mismatch repair proficiency, they demonstrate a higher complete response as compared with the patient with mismatch repair deficiency. Then they also look at the progression rate of endometrial cancer after the initial treatment, and consistently with the previous result, they demonstrate at 2 years, 3 years, and 4 years that patients with p53 wild type, so normal p53, were less frequent, had less frequent progression, and also patients with mismatch repair proficiency had less progression rate as compared with mismatch repair patient with mismatch repair deficiency. So they show that mismatch repair and p53 are predictive value for responding to progesterone therapy in patients with atypical hyperplasia. This instead is our report of our group on patients with endometrial cancer. We perform molecular classification on patients undergoing fertility sparing treatment in our institution between 2005 and 2021, classifying patients in the 4 molecular class. We identified 80 patients. However, when we went back to the tissue sample of those patients, we only were able to perform molecular classification in 33 of them, because most of the patients didn't have tumor tissue available, or for some other patient, there was a degradation of the sample, so we were not able to perform molecular analysis on the sample. So we ended up having 33 patients, which is one of the largest series published so far. And the prevalence of the molecular class is the following. We identified 9% of polymutated patients, 9% of mismatch repair deficiency, 25%, 76%, sorry, the largest group was the NSMP, the non-specified molecular subgroup, and a small percentage of p53. So basically in our population, the majority of patients were non-specified, patients with non-specified molecular profile. Then we look at several outcomes, but specifically we look at the complete response at 6 months, showing that no one of the patients with polymutated mismatch repair or had complete response at 6 months, while the response in patients with NSMP and p53 abnormal was statistically significant. In conclusion, we conclude that although a small number of patients limiting our findings, especially in the polymutated group mismatch repair of p53, we identified that mismatch repair deficiency patients responded to progesterone less had a lower proportion of response to progestin as compared to the NSAP. Then we perform also a literature review of the study published at the time before the publication of our result. As you can see, as similar to our report, the majority of patients undergoing fertility sparing treatment fall in the non-specified molecular profile subgroup. The second group in terms of frequency was the mismatch repair deficiency, while in the literature there are very few patients published with the polymutated subgroup or in the p53 abnormal group. So for this reason, draw conclusion on those, especially in the polymutated p53 abnormal subgroup is impossible. But when we look at the complete response in all the published study at 6 months, we identify that no specified molecular profile had a higher response to progestin as compared to mismatch repair deficiency, showing and this result is basically consistent throughout all the study that mismatch repair deficiency had a lower response to progestin. And this data should be taken into account when counseling patients for fertility sparing treatment. This is another study published very recently that, as I showed you before, confirm the result of previous study, and this paper from a Chinese group, they conclude that polymutation patients tend to obtain promising outcome, although I should stress that the number of patients is very small. They conclude that p53 wild-type patient demonstrate favorable outcome. Mismatch repair should be cautiously administered for fertility sparing, this because of the lower response, and the patient with the endometrium confined p53 abnormal tumor may benefit as well from fertility sparing treatment. And those are the conclusions from the ESGO-ESRE-ESGE guideline that were shown before by Dr. Pino. And they suggest that promising molecular classification should be performed in all patients undergoing fertility sparing treatment, is mandatory to evaluate for mismatch repair deficiency protein in order also to identify patients with Lynch syndrome. They also suggest that would be not very appropriate to perform conservative treatment in p53 abnormal, probably even though there are no, I remember those are only data from recommendation coming from a consensus conference. There are no data saying that p53 abnormal do not respond to progestin therapy. However, considering that p53 abnormal patients, they have poor outcome overall, driven due to a higher rate of distant metastasis, they are kind of suggested to evaluate and decide on a case-by-case for this. Finally, which is the management post-fertility sparing treatment for patients that complete the fertility sparing treatment? The management correct for those patients is represented by total hysterectomy and bilateral salpingo-oophorectomy plus or minus oophorectomy. Why plus or minus oophorectomy? Because there is no a priori reason to remove ovaries in those patients. Removal of the ovary doesn't have a therapeutic effect, and there are studies comparing overall survival in patients where the ovary were removed and where the ovary were not removed, showing similar oncologic outcome. And for this reason, the need for oophorectomy should be individualized according to patient age, probability of ovarian involvement that should be carefully evaluated by ultrasound. Should be considered the genetic and familial history and the presence of high grade of primary ovarian cancer or the presence of annexal disease. The indication for definitive surgery are obviously completion of childbearing, recurrence or non-response at 6 to 12 months of hormonal treatment, and disease progression either in the uterus or reservoir, even though there is some data in the literature showing that also a new fertility preserving treatment is allowed and could provide good results. Finally, another question that we always ask ourselves is, should we evaluate, assess the lymph node in patients undergoing fertility preservation in endometrial cancer? There are no data, again, of primary evidence, but this study, which is a collaboration between our center and the Mayo Clinic, could help us to answer this question. And as you can see, putting together more than 1,300 patients with endometrial cancer treated with sentinel lymph node, we observe that none of the patients with grade 1 and no myoinvasion had ITC, micrometastasis, and macrometastasis. So basically, the risk of nodal metastasis, also including patients with grade 2, was less than 1%. So we can conclude that the nodal assessment in those patients is not needed, except for specific cases, for example, in which there is preoperative risk at the imaging, for example, of having nodal metastasis. Thank you.
Thank you. Thank you very much, Francesco. And then my compliment for the beautiful presentation and for the hopes that we have now to face and to treat our patients. And I would like to have all of you, and then we will start the question and answer. We have received several questions from the floor, and then I would like to start also with Andrea. Can you come also here? Yes, I am waiting you, and then now we would like to have... Okay, thank you very much. Okay, we will start with you, and then we will go to Ida and Francesco. We have several questions. One is, and then it's also linked to a question for Ida after Andrea. For you, is what is the impact of obesity on endometrial cancer onset?
As previously told, the obesity helped to create a inflammatory milieu in the endometrium and create the condition for an ovulation, and so it's something that increases the rate of inflammation, and so a direct damage to the endometrial cells. So is one of the first step of the damage, and is one of the first stage for the creation of damage to the cells and to the development of neoplastic clone. So this is one of the first moments of the endometrial damage.
Thank you. And then now, Ida, a question to you. First of all, in the group that you have shown us where you have added metformin, I would like, it's a personal question, what is the incidence of obesity, and what are the incidence of diabetes in the individual or in their family or their families?
The mean BMI of our cohort was 25.
25.
Was the median, yeah.
Quite lean, huh?
Yeah, was 20. Yes, was 25. I don't know information about the family history of diabetes. I have information only on the personal history, and no one of our patients had a diagnosis of diabetes at the moment of the endometrial cancer diagnosis. So no patient with diabetes, and the mean BMI was 25. The best results of the use of metformin are in obese patients. They already showed this data, but anyway, it works also in non-obese patients for, of course, other kind of mechanism that he also was shown before, no, because only for the control of insulin resistance, but also for an anti-proliferative effect of metformin on endometrial cancer cells line. We have a lot of in vitro studies that show that metformin can strongly reduce the cell proliferation in the endometrial cancer cells lines.
Yes, thank you. And then we have another Narota question on that point. What was your dose of metformin used in your study?
The full dose is 500 milligram for 3 times a day. Of course, to reduce the side effects, we start with one tablet for day for 1 week, and then we continue to increase the dose, reaching the 500 milligram for 3 times a day.
Thank you very much. And then now one question, Francesco, for you. What evidence exists regarding the safety and effectiveness of fertility-sparing treatment for endometrial neoplastic diseases in patients with Lynch syndrome?
Yeah, fertility pressure-sparing treatment in women with Lynch syndrome and endometrial neoplastic disease require careful consideration due to the associated risk with this disease. In fact, it's essential to first of all, it's essential to thoroughly assess the presence of any concurrent or metachronous malignancy before initiating the conservative management. There was historically the idea of that patient with the Lynch syndrome should not be treated with fertility sparing treatment. However, things are changed in the last year, and also the last guideline allowed and present fertility sparing as an option, but it's important that patient must be fully informed about the significantly higher risk of disease persistent or disease recurrence as compared to the general population undergoing similar treatment. And given this risk, the decision to pursue fertility sparing in those patients should be made on a case-by-case basis and following a thorough assessment of risk, benefit, and a multidisciplinary discussion. There are no guidelines specific on this, but it's still possible.
Sorry. Thank you very much, Francesco. It's very precise on that point. And one, Andrea, you mentioned the association between endometrial cancer and polyps. I would like to make you a distinction. Ecco, what is about symptomatic polyps and non-symptomatic polyps?
As you can see, the symptomatic polyps are the polyp whom we have to pay attention. We must remove all these kind of polyp because the rate of endometrial cancer's presence is 3%, while the presence of the other polyp or asymptomatic polyp, the presence of preneoplastic and neoplastic lesion are lower. So, and it's important to note also the size of the polyp, because a polyp less than 1 centimeter without any abnormal uterine bleeding, it's possible to check and to perform a follow-up, even in patient perimenopausal women. So the symptoms is the leading cause of a treatment. So abnormal uterine bleeding in this patient could be managed. The patient must be assessed and treated always.
Thank you. And then for Ida or for Francesco, you choose. What are the most effective conservative treatment options for endometrial hyperplasia without atypia? Open the microphone, Ida.
The best treatment is the continuous progestin therapy. Of course, the gold standard is the levonorgestrel IUD because of the tolerability of the device. The hyperplasia without atypia rarely progress to cancer, and in most of cases regress spontaneously, but the levonorgestrel IUD helps the endometrial status to return to normality. It also suggests to perform a hysteroscopic guided biopsy to exclude a progression, he suggests to perform an hysteroscopic biopsy after 6 months of the start of the therapy with the levonorgestrel IUD. And we should perform it 2 times with the 2 consecutive complete response before to discharge the patient.
Thank you very much. And then we have a question from Maurizio Salvetti. Francesco, probably for you. PTEN expression, is it useful in prognostic evaluation in endometrial hyperplasia?
So you see, PTEN gene, okay. There are a few recent data on PTEN gene or ARID1A, CCNNB1, beta-catenin, or also estrogen and progesterone receptor, which are markers that we are trying to use to further stratify patients. However, data on those markers are still not strong, or there are not confirmation on the role. So it's something that is some group started to do, but there are not data that we can use in selecting patients for fertility sparing treatment so far.
Thank you very much. And then, Andrea, for you, the effects of progesterone on endometrial cancer, the prevention and treatment.
Yes,
and when we speak about progestogens, if you can make differentiation between one and the other, because they're not all the same, at least they don't seem to be all the same.
Not all the same. Anyway, in general, we must affirm that the progesterone must be always present in patient with the uterus right now. So we have the knowledge to introduce this concept. And usually we, as previously told by Dottoressa Pino, in perimenopausal women is very helpful the use of IUD, for example, because the introduction of IUD in perimenopausal period can naturally change from a premenopausal treatment to a menopausal hormone treatment if with the administration of transcutaneous estrogen, for example. So I think that in people with this kind of menopausal transition, one of the best examples are this one. And for example, NOMAC or the Dynogest is one of with the use of natural estrogen pills is something that very useful for the perimenopausal treatment of maybe abnormal uterine bleeding or in this kind of patient.
Thank you. And then we have a question from Peter Greenhouse that I divide for Ida or for Francesco, if you have, because I have never observed it. He asked, to what extent does pregnancy effectively suppress endometrial cancer recurrence during the pregnancy itself? Is extra surveillance indicated during pregnancy? In my few cases, I never had, but if you have another experience on that point, please.
So pregnancy doesn't have a negative effect of endometrial cancer, and no extra obstetric follow-up is needed during the pregnancy. We, of course, suggest to perform an endometrial biopsy before trying to conceive, just to be sure that we start the pregnancy on a normal endometrium, and then we perform the endometrial biopsy 30-70 days after the delivery, but no progression of disease was observed during the pregnancy.
Thank you. I had the same observation in my not so numerous cases that I observed during my career at university. But a question from Elena Rota, Francesco, probably for you. After a pregnancy, when we should perform a new biopsy or hysteroscopy, and breastfeeding could reduce the progression of the possible lesion? Francesco, do you?
Yeah, as Dr. Sapino mentioned, we usually perform a new biopsy after 1 or 2 months, or most of the time also 2 months after delivery. And yeah, breastfeeding could reduce the progression of the lesion. However, we keep follow the patient with ultrasound and biopsy depending on the histology result.
Thank you.
Furthermore, the best therapy that we can use in maintenance is a levonorgestrel IUD that is complete, that we can use also during breastfeeding. So we usually perform the hysteroscopy after 2 months of the delivery. In this setting, we insert the IUD and say to the women to really continue to breastfeed.
Thank you. And then we have from Alexandra Gomova, first of all the compliments for the brilliant lecture. But for you, Ida, she asked how often we should perform hysteroscopy and biopsy after treatment with complete response and delaying pregnancy.
Yeah, when we have 2 consecutive complete response biopsy, we do 2 complete response on endometrial biopsy. We suggest to perform the hysteroscopy every year, and we perform an ultrasound by an expert examiner every 6 months.
Thank you very much. And then now probably for you, Francesco, are there specific clinical scenarios or patient characteristics that justify offering fertility-sparing treatment to high-risk pregnancy who fall outside current guidelines? Because this is a major problem.
In general, it's better to treat always those patients within multidisciplinary team with oncologists and fertility specialists. Then case by case, there is some specific case, for example, in patients with grade 2, because we just talked about patients with grade 1 so far, which is the type of the selection for patient for which are based the guideline. But there are a few reports but with a very small number of patients showing also safety of this treatment in grade 2. And because of this especially, it's important now that we are moving from the old FIGO classification to the new FIGO classification in which grade 1 and grade 2 are merged together and in a single group called non-aggressive subgroup. In patients undergoing fertility sparing treatment, is important still to divide the patient in the 3 groups in order to keep this treatment safe, and in the presence of a very motivated patient with grade 2 but without myometrial invasion, or also with a very small myometrial invasion of 1 or 2 millimeters, but in patient with grade 1, there is still space for fertility sparing under tight control.
Thank you. Thank you very much. And then it's from Tevfik Yoldemir, a question, Andrea, probably for you or who want to respond. Any comments on the risk of endometrial hyperplasia or endometrial cancer with the use of basedoxifene plus conjugated equinestrogen as menopause hormone therapy?
But it can be possible. The use of this compound is possible. Even the SERMs show a little bit increased risk of development endometrial cancer in patient at risk. But this compound is possible in patient with a risk factor, so is possible. It's not recommended, but it is a plausible option.
Thank you. And then for Ida, for you, from Michael Samaha, why treatment is limited to 12-18 months?
The treatment is limited to 15 months because 15 because after
12 or 18, that 15 is in the middle. Then after 15 months, what we can do?
Yeah, after 15 months, if we didn't reach the complete response, we should discontinue the fertility sparing treatment, because the possibility to reach it in the future is going lower and lower, and of course the probability of a progression disease disease is increasing. That's why it's not considered safe to continue a fertility sparing treatment after 15 months without results.
Okay, and then what you suggest after that?
Fortunately, the surgery.
I thank you very much. Then, Francesco, for you, how does a patient's age influence the decision-making process for conservative treatment of endometrial and neoplastic diseases in fertile women? Very important. Take your time and think about.
Probably Livia, Ida, that usually follow more strictly than we do, will be able to give a better response. But overall, there is not a specific cutoff. We used to have in our institution a cutoff of 41, then 42, but in general in the literature there is not a specific cutoff, but they should be evaluated on a case by case, also evaluating the possibility of pregnancy for the specific woman. But I don't know if Ida want to add.
Ida, please, you can go on.
Yes, talking about pregnancy and age, only sky is the limit. It's always more harder set a clear cutoff. Of course, age is an important key point in the outcome of fertility sparing treatment. We have a clear evidence on it. The live birth rate in the women under 35 years is 30-35. The live pregnancy rate in the women up to 40 years old is 20%. So we always try to balance the oncological safety with the real chance to have a baby. Okay, because the goal of fertility pregnancy treatment is not to retain the uterus, is the pregnancy. If the chance to have a pregnancy also with heterologous fertilization is low, very low or impossible, we have to have the courage and be brave to say to our patient, this is completely unuseful to have a risk, oncological risk to retain the uterus. So there's not a clear cutoff. As Francesco said, our cutoff is 40, 41, 42, but we always discuss in a multidisciplinary team, discussing case by case every cases of women with age over 41 who want to preserve fertility.
I have an additive question to you. Also, in the patient who have a Lynch syndrome, you suggest to go to a novum donation eventually?
It depends if she wants to take the ovaries or not, but they should of course, they usually perform also the bilateral salpingo-forectomy during hysterectomy. It's a very hot topic. Of course, we suggest to have the pregnancy as soon as possible, so we can perform a complete prophylactic surgery after the wish to conceive is satisfied.
Thanks a lot. And then, Andrea, now we are going to the end. I have a final question for you, and then a final for all of you. But for Andrea, I would like to ask about the new trends in research about early detection of endometrial cancer.
It's the development of tools of artificial intelligence and deep learning model, and so to stratify risk factor and to find scores of risk for the characteristic of each patient. So personalized and precision medicine for this kind of patient. So the trend is on the early, not the diagnosis, but the interception of risk factor and the early treatment of the risk factor. So primary prevention with the technological and artificial intelligence tools.
Thanks a lot. And then
there are a lot of literature.
I'm sorry, we are now approaching to the end. And then it's a very important topic. And then I would like that each one of you, Francesco, Ida, would like to start ladies first. First, Ida, I would like we are still 150 person in our webinar. We would like that you give your suggestions. You know, you have in the institution where you are working, you reach numbers that are not normally so frequent in the general practice, also in the biggest university. Then please give us your own comment, and the same for Francesco. And later on, the same, the final, we will make a trip going in the reverse way to Andrea. I would like to have your comment.
So the title of my work is Sparing is Caring. It's important when we are talking with a women with endometrial cancer who wish to conceive, never always think about the chance to have a pregnancy. We should immediately send the patient to a tertiary care center where they can have a multidisciplinary approach and can have all the best that our knowledge can offer to her. So sparing is caring, but in the right place, in the right women, with the right tools.
Thank you. Francesco, what do you, concerning your topic, what do you like to give us invite for the nice population of people with us?
Again, I'm going to stress the importance of the center of the presence of all the figures necessary. For example, as I show you now, molecular classification is increasing the importance. So there are so far few centers performing molecular classification in Italy, so this is still an important part. And then the presence of advanced ultrasound specialists, like we have fortunately in our institution, like Dr. Pino, which are really helpful for us. I'm a surgeon and I spend most of the time in the OR, so I really need the help of ultrasound specialists providing us their evaluation and their insight on the presence of even very suspicious lesion that should be biopsy or that should be evaluated. This is my conclusion.
And then now, Andrea, for you, you know, we have clearly seen that you have a great, we have an endometrial cancer type 1 or type 2 or type 3 or type 4 make huge difference. Difference is also from type 1 to type 2. Then I would like to have your advice and suggestion how to what we have to do as gynecologists as to achieve the diagnosis as early as possible on the basis of the patient's symptoms.
I would like to stress the topic. There is a very simple message. My message is that if we want to intercept the risk factor early, we can treat and we can participate to early prevention. To make early prevention is very simple because you can treat in our setting, clinic consultation setting, or during our routinary activity, we can treat anovulation, we can treat PCOS, we can treat obesity with the use of normal hormonal compound, even in young patients. So if we do that, if we teach lifestyle, healthy lifestyle, we can reduce the most important risk factor for perineoplastic, neoplastic lesions. So I think that is a very important, simple message, but primary prevention came first. Then we have to check for the leading symptoms and to speak the same languages about the indication to the first exam and evaluation and patient assessment. So it's something very simple.
Thank you to all of you. Thank you very much for being with us. Endometrial cancer is something which is growing, as obesity is growing. It's an epidemic all over the world. We have a major role and major action to do to prevent that one, to early diagnose, to treat, to make possible fertility, and then to make a safer hysterectomy after pregnancy achievement. Then, dear Ida, thank you very much.
Thank you.
Francesco, thank you. Dear Andrea, thank
you.
Much. And then I would like to thank all our participants and to remind to all of you then in the beautiful Riga in Latvia, 1922 of March, we will have the 16th Congress of the European Society of Gynecology. Join us. It will be a fantastic event. and certainly it will be hopefully in a more peaceful world. I thank you very much for your presence, and I invite you on the 23-25 of January to our next event, which will be very soon announced. Thank you very much. Thank you, Ida. Thank you, Francesco. All my regards to my friends at the European Institute of Oncology in Milano. And thank you, Andrea. My regards to the Department of OBGYN in Pisa. Bye-bye.
Thank you.
Bye.
Bye.